of time, if that's okay. So as we said, we are starting to record. Good afternoon. My name's Louise Warren, for those of you that don't know me, and I'm the regional SEND manager for NHS England in the East of Region. Children's nurse by background, and I was a DCO, so lived and breathed the tribunal process, as many of you here on the call are. And my co-chair today is, without his cookie.
Hi everyone. So I'm Jack Walker. I'm the designated clinical officer for SEND for the Suffolk and North East Essex ICB, and a clinical psychologist by background.
Brilliant, wonderful. So today we're just going to share, or I was asked to share, the journey that we've been through in the East of England around enhancing the knowledge of health practitioners in regards to the first tier tribunal process. As we mentioned earlier, many areas are really struggling with this, and the increasing demand that we're seeing around health related tribunal requests. And actually in the East of England, it really became what we describe as a wicked problem that we'll go on to discuss in a bit more detail. Just to caveat this, we are not legal experts in any way, shape or form, so we can't give legal advice. We're just sharing our journey, but also what we learned through the process. So we really hope you find it useful. But again, pop it in the chat. The slides will be available for everybody as we move forward. So as I mentioned, we're in the East of England, so we go from sort of Southend all the way up to Milton Keynes. So we've got 12 SEND local areas and 6 integrated care systems. We do have Milton Keynes that is actually part of the DFE South East group, so some border challenges there around how we work. And we've also got Essex local area, which has got 3 ICBs that feeds into it, so one of the more complex across the country. So a few challenges, but we do enjoy a challenge. The latest SEND data says we've got over 70,000 education, health and care plans, by 7,000 each year. But actually we're seeing plans are not ceasing as they were before. Young people are staying in education a lot longer, and those plans are continuing. So the increased demands on particularly our health services, therapies, community paediatricians is growing at quite an exponential rate, which I'm sure many of you will be in a very similar position moving forward. As we put on here, we were the second, we're now the first highest tribunal appeal rate in England. It's not a badge we hold proudly, I have to say, because that shows the experiences of children and young people are not where they need to be. So how do we move that forward and support? We've got 12 designated clinical officers and 5 deputy designated clinical officers and 3 DMOs within our area. And we work really closely as a forum, as a monthly group, to collaborate, champion and empower SEND across the region. My post was the first in the region specifically for SEND. So we were really on an improvement journey moving forward. We've got identified ICB exec leads in each of our ICBs. There has been some changes, but we're working really closely with them. And we've had, under the inspection framework, we've had 2 inspections. One area is published with inconsistent experiences for children and young people. One area is still waiting publication, and we've still got 3 areas on accelerated progress plans. So it's busy, but I don't need to tell you because you're all working in it and feeling it. So some of the colleagues on the call here will know that as part of our national oversight, we ask ICBs to complete maturity matrices, or heat maps you may have called it for. And I just wanted to share what this looked like in the East of England. So you could see these were our key areas. And as you can see, one of the really overwhelming key areas was around SEND and the law training, and specifically around health. And many of our health practitioners felt really unconfident, I suppose is the word, around the tribunal process, what their role was, what information they could give. And our DCOs and our DMOs are in some places overwhelmed with the amount of requests that are coming in from local authorities. Some are incredibly late that come in, some are very complex, and Jack will go into what that looks like in his system a little bit later on around what that looks and feels like. But we weren't really producing a comprehensive and robust and sometimes lawful response to tribunal requests, and ultimately that had a really negative impact on our families that we were caring for. So we put there a wicked problem. You all know it. We've got a wicked problem in the East around tribunals. We've got some DMOs that's all they do is tribunal work. And we really needed to look at a way that we could empower, enhance and upskill our health practitioners, specifically around the health responsibilities, so that actually DCOs could do more than just tribunals and have the strategic oversight, that providers were empowered to attend tribunals, to write reports, but also fully understand their responsibilities alongside their exec leads and SROs, understanding what their responsibilities were, the escalation process, the tribunal data moving forward. So what did we do? We identified the issue, and I think it's really important to say that this journey has very much been led by our designated clinical and medical officers, and the scope and the audience and the outcome came from our monthly meetings. The key question that many people will ask was, how did you fund it? How did you fund that? We had a small pot of money last year from the national team. I don't think that will be repeated, I've got to be honest. So funding is an issue, but we did get that to undertake this piece of work. What I would say around that, and I forgot to say it in the last one, is that if you wanted any kind of training, really, there isn't any money at the moment. I know I'm being recorded, but we all know that it's really challenging times. Write a business case, because you never know when a pot of money might pop down and you can take that off the shelf and say, actually, we need this, because actually the turnaround time is quite short. So if you've got something there, then it's really worth doing. Within NHS England, we have to put an expression of interest through the NHS National Legal Team through a requisition. You don't know what you're going to get. We were really, really fortunate. They go out to find who would be the best person to do this. And we were linked in with Bevan Britton and Deborah Jeremiah, who is a SEND legal specialist and works in the courts and for families and for ICBs. So what did we ask? What did we want? What would the training cover? No big surprises here. Legal responsibilities for health services, health requests, particularly focusing on children not known to service. We were seeing a huge amount of children in tribunal that weren't already known to specific services that they were requesting advice and assessments in some places for. The role of the DCO and DMO, what was their role and what did they need to undertake? What needs to be included in the health report? Did they need to do a new assessment? We've all been there when we've been told by the LA we need a new assessment and it needs to be done in 2 weeks. Actually, what's our comeback? What's the robust, comprehensive and lawful response? Preparing to be a witness at tribunal and the court process, responding to non-binding recommendations, how we involve our senior responsible officers and commissioners in this. It doesn't sit alone with the DCOs and DMOs. It's a whole system approach within the ICBs and providers. And actually, and I mentioned it before, the elephant in the room, the independent assessments. What's our response to those in the private assessments? What is our role within that? And that was our ask. That was our ask to Bevan Britton. How can you support us within this? So we targeted the audience and we had 3 sessions, virtual sessions of 2 hours, and we had a range. It went through the DCOs and they identified who the appropriate audience was, and we kept the groups to 30 per session, 30 to 40, so that they could have chance for discussion, for questions we could explore in a little more detail. So we had over 100 healthcare professionals for the first 3 sessions, and you can see there was a whole range from heads of service, DCOs, commissioning leads, exec leads, frontline practitioners. We also recorded one of the sessions and we had one of the sessions in an accessible version as well. And there's just a little bit there about Deborah and her background. So we were in really safe hands around what this looked and felt like, but really clear in the East of England, we didn't have any we didn't have any sort of baseline really of knowledge. It was a whole range of professionals that were coming. So actually, how could she support us in that process? And she took the challenge on beautifully, if I do say so. So we had the first 3 sessions and we evaluated it. And as you can see, the confidence levels, about 46 people responded, so just shy of 50%. And all confidence levels went up for all practitioners. Some practitioners were still very nervous. Some practitioners were still quite just wanted to stay well away from any kind of tribunal. But how do we support them and bring them on board around that? And as you can see, the majority of training met expectations. sessions. The partial was specifically around the role of the witness, and they wanted to really deep dive into what the role of the witness is, what it feels like, and what can be expected. I mentioned on the previous call there were some quite traumatic experiences that were shared, and Alison Markwell, for those of you know, is a layperson on tribunals, so she said that we've got much better, and there's a lot more training around for the judges, but also a whole range now of new professionals that are lay within the tribunal process. But still, we had to acknowledge that these were really challenging times for our professionals going forward, and who's the right person. The key areas that came out of the first sessions, and there was a number, but I've honed them down into 3, was one around your commissioning parameters. Actually, you don't need to go outside of your commissioning parameters within the tribunal. This is what you commission in a core commission service. And if the child needs over and above what that is, then you use the individual funding review process, or you use an additional process outside of the tribunal to meet that, but you stay really clear to your commissioning parameters. If parents are asking for something that isn't identified as a clinical need and isn't commissioned, that can be your response. And Deborah was really clear. I think it was a bit of a light bulb moment that actually you can't be all things to all people, and judges absolutely understand that this is not a finite, you know, we can't just spread as we need to for families' needs and wants, and also professionals as well. So it has to be based on clinical need, and it needs to be equitable for your population. So I think that was a real light bulb moment for us. What's the core offer? And that includes your local offer and your graduated approach. So for those children that you don't know and haven't been known to the service and don't meet the criteria, what is available outside? What is available within the core local offer? And it's absolutely right and proper to be able to provide that information as well. And also a position statement. So where are you at the moment? What are your waiting times? What does that look like? What is your threshold for your service? What is your criteria? We're being really, really clear. And all that information can be part of your bundle moving forward, you know, as part of your information from health. But as you can imagine, there were many, many more questions that were brought up from it, and many more areas that wanted to be explored. So you can see some of them there: using law to strengthen clinical argument, advice versus assessment, which we're still grappling with in the East, although we've got a slightly stronger, I think, view on it and response. Case studies, so we can really learn through that experiential process, contents of reports, and a system-wide approach. And then these are just some evaluations just to show the success of the training for the first time round. We did do it on Teams. In future we might do face-to-face. It really led to, okay, we need to know more. We need to know more about specific areas, but it was welcomed really strongly, and as Jack mentioned in the previous one, real appetite to take this up and to move it forward. And now I'm really pleased to welcome Jack, who's our DCO from SNE, who's going to talk through what they're doing in Suffolk and North East Essex and the learning that they've taken. Thanks, Jack.
Thanks, Louise. Yeah, so I'm the DCO for Suffolk and North East Essex ICB, so we cover the areas on the screen there. In terms of rough numbers, we have approximately 8,000 EHCPs in Suffolk, and about kind of 3,000 to 3,500 EHCPs in North East Essex. So that's kind of the area that we cover. I say we because it's not just me. Lucky enough to have 2 deputy DCOs as well, Holly and Joe, who are from speech and language therapy background and a school nursing background. So we've got a mix of different skills and experiences in our DCO team, if you like. Brilliant, thank you. So we've got some Suffolk data here. So Suffolk being the biggest patch is roughly kind of 2/3 Suffolk, 1/3 North East Essex, but just to show really the increase in SEND tribunals for health, the extended appeals tribunals, from 10 in 2021 to 25 in 2022. And at the moment, across the whole patch, we're working on about 15 SEND tribunals that relate to Section C and G, those extended health appeals. And since the beginning of last year, we've finished work on 43 SEND tribunals that apply to Section C and G. Majority of them haven't gone to hearing. But obviously, as you all know, a lot of work involved in whether they go to hearing or not. in trying to kind of reach that agreement through the working document phase. And I just thought it might be helpful here to just put, we use a tribunal tracker Excel document to track all the active tribunals that we have, and those are some of the headings that we use to try and understand obviously where we're at as a team, but also any process issues that might come up. So the date of instruction might be different to the date that we are informed, for example. And then if there's a big lag there, then we can pick that up with the local authorities as to making sure that we have enough time to respond as a health system to the tribunal as well. Next slide, please. So as Louise mentioned, really good appetite, really high appetite from our clinicians in North East Essex and in Suffolk to find out more about the SEND tribunal process as applicable to health, and from us as a DCO and DMO regional forum as well. I mentioned in the last workshop that there is tribunal training out there and SEND training out there, but I was looking for something specific to health, and that was really quite challenging. And the training that I did go on didn't really, it could be a 3-hour training session, but it might spend 5 or 10 minutes on health. And it didn't really feel like there was enough out there to kind of best inform what we should or shouldn't be doing. Michelle, if it's okay, can we take questions just at the end? Because we did run over last time.
Yeah.
So just mindful of that. So these are just kind of some of the take homes I took from the training that we got from Bev in Britain. And as Louise mentioned in the previous slides, the issues around kind of parameters and commissioning and how the SEND tribunal can't kind of separate that from the issues coming up was a kind of key one, a really helpful one. And also just learning, I suppose, that different ICBs have different levels of legal representation in the SEND tribunal. We can seek external advice, legal advice, from a kind of lawyer solicitor, which is helpful. I think that others maybe don't have that option, whereas some ICBs are represented by a barrister at the SEND tribunal. We don't have that. So just understanding the landscape, I suppose, was helpful to see where different ICBs are at. Next slide, please. Yeah, so we were getting through a few SEND tribunals where there seemed to have been missed opportunities, I suppose, for reaching some kind of agreement with the appellant or the parent or carer, whoever's bringing the tribunal, earlier on in the process. So some were kind of almost like complaints through the order. And so we kind of asked that question of Bev and Britain during the training, and their view was that, you know, those kinds of things aren't really the role or the remit of what a SEND tribunal should really be. And there should be other ways of going about kind of solving those maybe earlier on in the process. And I'll talk a little bit about mediation later on as perhaps an opportunity to get in there earlier to solve some of those issues. Next slide, please. Brilliant. Okay, so we've had some differing recommendations from tribunal panels around private reports and how that should or shouldn't be reflected in an EHCP. So the way that we had always done it was in section C to say it was private, because then that kind of explains the context of maybe perhaps a lack of provision in section G if that's being privately provided. However, then we had another tribunal say, nope, take that out. It doesn't matter where it's come from. That's a need, which I agree with. But then kind of this wording came through from another tribunal around why the tribunal felt that the word private should be included in the diagnoses listed in section C. You know, when health professionals are using an EHCP to develop an understanding of the child or young person, if those diagnoses and records don't exist on any NHS platform, which they might not necessarily if it's a private diagnosis, then the EHCP should kind of act as a vehicle to communicate that to the audience. So again, I just thought that wording was helpful to try and kind of understand what we should or shouldn't be doing in that situation. Next slide, please. And again, in terms of the provision itself in section G, we've had this kind of guidance around what section G should include and what it perhaps shouldn't include. And I think, and I mentioned it in the last workshop, but I think it's not always clear for people, and I think that that's where EHCPs are not necessarily clear when it comes to section G. I think there's lots of people that understandably would assume that any health provision that the child's receiving should go in section G, because that's what it's about, health provision. But I think in the tribunal space especially, what's important is that that's NHS commissioned provision, and I think that gets lost and is not fully understood across the system. And I think that there's opportunities for us to get that in earlier as well, just to explain why some things may or may not be in that section. Next slide, please. So just this is my last slide. So just thinking about issues that come up. So cross-boundary working, we've had some issues where a GP might be the child's GP might be in one county, their school might be in another, their social care might be in another, and understandably, again, parents don't always understand how that all works together, and neither sometimes do professionals as well. Let's be honest. So I think there's work to do around communicating that through the local offer platforms and places like that, in terms of what you might expect depending on where you live, if you do live on a boundary, and we know that's an issue. Transfers in and out. So we've seen some tribunals where, from a health perspective, plans have moved into the county, but we haven't ever seen them. And so when it comes to the tribunal, there are things in section G that we wouldn't have necessarily agreed to, or aren't necessarily kind of provision that is in place. So it goes both ways, perhaps provision that should be in place, or provision that is kind of old or shouldn't be there, private provision, for example. So we're working with the local authorities to try and get better processes in place to see EHCPs that are moving into the county, so that we can understand that earlier on and we can trigger reassessments if we need to. In that realm as well, we're looking at the electronic platform that one of our local authorities started to use for EHCPs, and us having access to that, being able to sign off section C and G more quickly, more efficiently through using electronic resolutions, which will hopefully be helpful. And I mentioned mediation earlier. So again, we've been working with one of the external providers of mediation in Suffolk at the moment to understand health issues that are coming to mediation, because at the moment we don't have any oversight of that. So to understand the kind of issues that are going to mediation, to understand how many of those are then going to tribunal, and also from the local authority around how many of the health extended appeals have or haven't gone through mediation, to try and gauge kind of where we're at, and to try and intervene, I suppose, or getting early to try and stem some of the flow of the extended appeal tribunals. Again, it feels like another opportunity that we can work on with the local authority and the mediation services. And speaking directly to families, I've said it's a future improvement. We do it, but I think it's something that we could always do better at. And I think there's an acknowledgement that by the time we become involved and we learn about a tribunal, it's new for us, but it's not new for the family. And they've had to go through all kinds of difficult scenarios, I suppose, to get to that point. And I think it's about us acknowledging that, and also kind of clearly explaining who we are, what our remit is within this, and how we can hopefully help. As I say, kind of through the working document, there's a lot of opportunity to prevent needing to go to a hearing in some cases, but I think that could be done even earlier in some instances. So yeah, so in summary, the training that we got was really well attended from loads of different practitioners and therapists across SNE, and it's been really helpful in terms of thinking about how we can better respond to tribunals, and perhaps reduce the need for some of them as well. I think that's me done.
Brilliant, thanks, Jack. And I think it's important to say that we're on a journey here, so you can hear how much that Suffolk and North East Essex are having to review and do. And it is very much about robust processes that are in place, or putting them in place if there aren't that really clear communication, and also the data. I do know there's a lot of questions in the chat, and I hope to answer some of them as we go through, but we're doing all right for time at the minute, Jack and I, so let's be optimistic from that. So we had the training, you've heard the positive comments, but also the challenges really to bring it through. But the next step from the first round of training was to ensure all the resources. So we've developed a toolkit for our practitioners that involves an EHCP sort of breakdown of advice from Bevan Britton, PowerPoint presentations, the video recording, and also key facts and messages has gone out to all health professionals across the Eastern region. The DCO, we really looked at the analysis of the training. What are the key themes and actions? What can we focus on? What do we need to prioritise? Do we need to commission additional training? Can we commission additional training? And as I said, key resources for the ICBs. So then what we did again is we did another round, but we called them workshops this time. And I think this is really important because this was the next steps. This was, I hate saying it, but a bit like the meat on the bones, if you like. So we had send in the law, we had what the responsibilities were, but these key questions that kept coming up was around reiterating the health responsibilities, commissioning parameters, because someone put in there around when the appeal's lodged and then all of a sudden health and care start appearing when it's actually for a placement, and you see referrals coming in, and Deborah was very clear that actually stick to your commissioning parameters. So if that child does not meet the threshold for the service, what's the local offer around that? And that's your response alongside your commissioning parameters, your local offer and your position statement. Legal advice at ICB level, Jack explored, we didn't really have any specialist send advice in the east of England. It wasn't something that we went to automatically, but other areas do. They have drop-in legal clinics with send specialists. They have in-house, they commission in-house send specialists. So actually, is that something we need to explore? Good communication pathways, early identification of these. We've all had those that you're given 2 weeks to get a full assessment and to get your bundle back within that short amount of time from the local authority. And also, what's the role around capacity to strategically review tribunals and the enormity and the weight that sits with the DCO around that. So these sessions were particularly focused at executive leads for sending ICBs, SROs, DCOs, heads of service, and our commissioning managers to really hone in that message around what we need to do to provide, and I say again, a robust, comprehensive and lawful response to, you know, achieve more positive outcomes for our children and family. So the outputs of that session, they were workshops. They were dynamic. We had over 100 people again, and we broke it down into 2 ICBs per session so that they could have that dynamic conversation. Key message, this has to be in the best interest of the CYP, and that is paramount. Children and young people first. It's person-centred, it's dynamic and it's compassionate, and we often lose that within the send tribunal process as we're arguing over funding and when it came in and when it's got to be back and who's going to go. There's a child at the centre of it, and that was a real key message that came out. Effective communication with the family, picking up that phone as soon as you know, stopping it at an earlier time. Actually, is it a complaint? Is it an individual funding review? Do they understand what they need? Do they understand what their child needs? And what is the opportunities for them around that? The governance and oversight at ICB level, and I don't know about your areas, but having worked in what was the CCG and then ICB, is actually, do our exec leads know around the tribunal? Do we have the data? Is it on the risk register? Does everybody understand it? Are we talking about tribunals? Because I don't think we are, certainly in the East, as much as we need to. So how do we empower and have consistent approach across the Eastern region in response to that? Commissioning parameters and how we look at that, how we respond, how we get our commissioners to look at what that is, to use our JSNAs to really interweave it within all our processes to address tribunals is an area that we're really, really looking at. Private reports and assessments. We know that many of our cases end up in tribunal if we don't have the right health information in there. So what is that right health information? But again, staying really clear to the commissioning parameters. And one of the things, Ruth, I saw you mentioning that increase in 19-year-olds. Deborah was really clear that pinch point is around transitional and transitional planning. And you often get a young person that needs speech and language therapy and they're 20 and you're like, we haven't got it, we've not commissioned it, what do we do? And then actually that has a very negative impact on that young person moving forward. So there's something about really focusing on those transitional pathways and understanding what the commissioning parameters and the position statement is around that. And again, this is just what we learned from that and the work that we need to do moving forward. I don't necessarily have the answers, but just what we need to think about to provide that robust, comprehensive and lawful response. So we've not finished, as you can imagine. We are on a journey and we're working together to develop these as a region. But what we've done is we've produced the toolkit. We're also looking at development of regional templates, particularly around witness statements, about position statements. So actually that we're all offering the same information, if you like, but with some local nuances and local commissioning. We understand that. We're also very aware that talked about postcode lottery, Christine did earlier on the session, but actually even in one area you can have a very different offer. So what does that look like? Myself as a SEND manager is able to support with complex case discussions, and that is ongoing. We're also looking at some additional sessions around commissioning funding streams that interweave between continuing healthcare, children's continuing care, section 117s and SEND, and what that looks like. And also what our practitioners really asked for, the role of the witness, and mock sessions around that as well. And it was great having Alison in the last one to say actually she's got something around top 10 tips for her practitioners. So I am going to get hold of that and hopefully we can share that, because she is a lay witness now on the tribunal, just to explore. And what we haven't done, we've evaluated the sessions and we heard from Jack what actually the difference it's making on the ground. But actually we need some measurables. We need to understand what impact this is happening, but also to take a stock and say, okay, that works, that doesn't, really looking, but also understanding what our tribunal data is telling us. And we don't have that at the moment. It's in no way or form a sophisticated process. So how do we ensure we get that? And how do we escalate that up to our ICBs, exec leads and our board members moving forward? So Jack's just put some links that he's found really useful, and you've also got the legal links in the PowerPoint slide moving forward. And that's our journey in the East of England around what we've been doing to try and enhance and upskill practitioners. It's a long process, it's not a quick fix, but actually the key elements that we've learned about child first, child-centred, which we should anyway, but they do get lost in this process of referrals and what that looks like. But also, I think really clearly around our commissioning parameters, our integrity as health services and standing strong and taking an active participation in the tribunal process, I think are probably the key learning coming forward. So I hope that's been useful. Now the chat's been pinging. I've got no idea what's been happening in the chat, but I don't know if there's any questions that I need to pick up.
I've tried to respond to some of them, Louise, as you've been talking. Interesting point from Michelle. Michelle, I didn't know if you wanted to. I've got 5 minutes to talk to that a bit.
Hiya. Yeah, so I did start querying when you said health, whether you meant section G or content of section F, because we know that our health professionals deliver a lot of that in speech and language therapy and in occupational therapy. The problems I'm finding is I do a really robust DCO report for the majority of tribunals when I've been given enough time. So I work with our providers about what's reasonable, whether it's within our thresholds of provision. For ABA cases, we've got a position statement that includes all of the relevant research up to 2022, so it does need a refresh. And we'd actually countered using certs, because that's our universal and specialist offer through educational psychology and speech and language therapy, and it's been trained into schools. Yet the judge absolutely overhauled us and said, no, ABA has got to be delivered, even though we created this kind of like bespoke approach to meet a need. So I just wondered what your advice would be around that, because I do wonder how the re-questioning is an interesting concept, because I've never known it be done successfully yet. And I just wondered how that information around that could be shared across the DCOs to provide a little bit of confidence around the challenge that could go back to a judge, especially when it could be assessed that undue harm could then be affected in a child in later life, because we know there's lots of evidence and it's not in the best interests of the child either.
Yeah, so what I'd first say is, obviously I'm not a legal person at all. I'm a children's nurse and I know a little bit, but from what we learned, Michelle, and I think I think actually what you described is what we're striving for in terms of those position statements and how we move that forward and empowering our providers to be able to do that. There's a little bit of a disconnect at the moment, and I think that's what Alison was trying to reassure us, that actually they've got some more lay people that are specialists within children's services that are taking it, and judges are having more training, but there's always going to be that then says that they need this. And the only thing I can say from learning from the training, Michelle, is that for ABA in the future is about having a legal oversight of that from an ICB perspective, because it sounds like you've put all of this information in and they've still gone, parents want this, but actually, and then the only thing for me that was missing was potentially an ICB send specialist to say, absolutely, you've put everything in place that you can put in place. But the clear message to us was the commissioning parameters is for health services. So whether it's in F or whether it's in G, it's the same. That's your commissioning parameters. This is what, now, of course, with F, if the local authority want to provide what the parents have got privately, then that's another discussion, isn't it, moving forward? But she was very, very clear that you stick to your commissioning parameters, and if ABA is not within your core commission service, then it's not within your core commission service. And that was very clear, the message that we got back. But I think it would probably be useful when you're facing with that, and it's when you've put all that information in, that time and effort to then get that back and to say, now, if you think it's potentially a safeguarding, then you have to get your designates involved, as you would do. And Deborah, I think, Jack, you'll hopefully agree, but Deborah was very clear that actually sometimes it does overlap. We do get that safeguarding and send overlap, and actually what is it? And that's why she was very clear what's in the best interests of the child. And of course, sorry, Jack, did you want to come in then?
Well, yeah, I mean, I don't think the training kind of solved that issue around if a judge or panel still recommends, well, in section F it's not recommended, is it? They state that, you know, it's kind of what the local authority, you know, we haven't kind of solved that one. But yeah, I mean, the conversation around safeguarding was if parents want certain provision in section G but they're not letting their child be assessed by an NHS service, for example.
We've had that
or you know, multiple refusals to assess, you know, so the ICB or the NHS aren't refusing to do anything, they're offering assessment, but no one's referring them, or they're declining to come along for an assessment, then that might kind of move into the safeguarding realm depending on the context.
And also, great point, Jack, also to provide that information that actually you've offered 3 assessments and they've refused them all from the NHS. So actually, and I suppose the other thing is around the non-binding, Michelle. So if it was in health, obviously ABA wouldn't be, it would be more in section F. But section C and G is non-binding. So you'd have to have a good reason not to.
He was going to put it in section G, because then I could have gone, actually no, and provided all the relevant evidence again. But they didn't, they chucked it in, and they commonly do move. So where there's tricky conversations, the judges will commonly move the G to F quite easily, actually. And it really, because I go to a lot of tribunals because I find them helpful. I think you can get a better picture of the child's needs, and you can make, you know, you are in a position then, though, that you have to make swift decisions about then what needs to be in section G. But it is massively helpful if you've got the support from a governance structure within your ICB, that you are able to make those decisions.
Yeah, absolutely. And I think that's one of our key learnings, Michelle. It's around making sure that we've all across the region got the governance, got the oversight and the escalation, and that you can raise concerns over certain areas of care, which we do see, unfortunately, a fair amount, don't we? But there's something around what's in your gift, and section F often isn't in our gift, and you've put all that information in place. It's very difficult, but I think case studies are really important in empowering and sharing, and I think I would like to see this work continuing around how we can empower the judges, but we're not there yet, unfortunately. This piece of work hasn't, and I'm not sure will, but focus on actually when you disagreed with, from that perspective. So probably not that helpful, Michelle, but a great question to explore and discuss. Thank you. I don't know if there are any more. I know we're up to time, and Tamara's very good at keeping me on time. Jack and I are very happy to take any questions if there's any more that comes through. But I suppose just thank you all very much for your time. I hope you took something out of today, an element of it. But if anybody's looking at putting it into their own areas and want to chat through what we did in a little bit more detail, or if we can help in any way around the requests and cases, then please do just let us know. But just a huge thank you for your time and for listening, and thank you to Jack and Samara for keeping us beautifully on track.
Yeah, thank you very much.
Take care, everyone. Thanks, Michelle. See you soon.